Hello everyone, this is Drew Gibbs from AIDS United. Just want to start off by thanking you all for joining this webinar, The Present and Future of Public Charge for Immigrants with HIV. I'll be joined by Jackie Vimo from National Immigration Law Center and Nana Khanna from the Positive Women's Network USA. Just before we start, some housekeeping issues. Webinar and audio and recording. This webinar will be recorded and we will be posting a copy of the webinar later for your future use. And you are all in listen-only mode. So if you have any questions, please type it into the question box on the bottom left of your screen, and we will get to the questions when we're able to. Also, just by way of plugging, AIDS Watch is soon, April 1st and 2nd of this year. We encourage you to register now before March 9th, when the registration price will go up from $35 to $70. It is the nation's largest constituent-based HIV advocacy event, and we always love to have as many people here from as many states as possible, so we encourage you all to sign up before March 9th. Today's agenda, I'll do some welcome introductions, followed by Jackie's presentation, Public Charge 101, Public Charge for People Living with HIV, and then Nana's Public Charge Implications and Actions for the HIV Community. Some brief bios on Jackie. Jackie Vimo is policy analyst who oversees the Economic Justice Program at the National Immigration Law Center, a national organization that engages in policy analysis, litigation, education, and advocacy to defend and advance the rights and opportunities of low-income immigrants and their families. Nana Khanna is the Executive Director of Positive Women's Network USA, a national organization that advocates for local, state, and federal policies and programs for women living with HIV. All right, for this webinar, The Present and Future of Public Charge for Immigrants Living with HIV, I thought we'd start off with a quote from current Health and Human Services Secretary Alex Azar in his most recent blog post highlighting the administration's Ending the Epidemic plan. He said, "We have the tools available to end the HIV epidemic." And this is something that you will hear said quite often. It was in the community-driven roadmap for ending the HIV epidemic by 2025 that was marshalled by AIDS United and the Act Now and AIDS Coalition. But given this administration's track record on healthcare and the well-being of immigrant populations, it's only natural to question who exactly the tools in the HIV toolkit will be available to and who will be denied access to them. This webinar, The Present and Future of Public Charge for Immigrants Living with HIV, we hope to provide a comprehensive overview of what the Trump administration's proposed public charge rule is, who it will affect, and in some cases is already affecting, and how HIV advocates and HIV service providers can fight back against this rule and work to ensure immigrants living with and at risk of contracting HIV in the United States have access to health care and other public benefits they need, while ensuring that they are not at an increased risk of deportation. Some overarching questions to think about during this presentation that will get into the nuts and bolts of the public charge rule are, will immigrants living with HIV and affected by HIV have access to the tools they need? And also, can we end the HIV epidemic in the United States if the Trump administration's proposed public charge rule is enforced? I will now hand it over to Jackie.
Great, thank you so much, Drew. So I am going to try and do as quick as possible an overview of where we stand right now with public charge, and specifically with how it will impact people living with AIDS, HIV and AIDS, and their family members and communities. I'm just really going to talk about what's the status, what does the policy look like today, and what's changed and what could change, and how we can talk to folks about it. So just in terms of the status of the proposed changes, I think many people that maybe are on this call were really amazing in participating in submitting public comments to the notice of proposed rulemaking. We got over 250,000 comments. Actually, it's up to about 266,000 today. They're still uploading the comments that are coming in. Basically what happened is there's been two things that happened, and I'm going to talk about them separately. One is that in January there were some changes to something called the Foreign Affairs Manual, and then secondarily the Department of Homeland Security published this rule, a proposal to change what public charge is. And We're still in the process right now, just so folks know, of having them review all the comments that people submitted. Again, lots of really great comments from AIDS United and Positive Women's Network and African Services Committee, lots of groups that just really did a fantastic job of driving comments to talk about how this would impact people living with HIV. So we're still waiting. It could take another few months for this rule to go into effect. If it, it could, they could decide never to make the rule final. There will be court challenges, but I think that the long story short is that we're still in a holding period right now. And even if the rule went into effect as soon as possible, there's still in the rule is a 60-day waiting period before the rule is in effect. So let's say they magically read all the comments by next week, which isn't possible. They'd still have to have 60 days of implementation. So all of us are going to have time. I think just the most important lesson now is things are still in limbo, and we're going to have time to sort of figure things out. So, so in terms of what the policy today, just as I think probably many of you might have already been part of a 101 webinar, but I'm happy to answer sort of any kind of technical questions or basic questions. But basically, the way that public charge is defined today is that a person is a public charge if it is a person who is likely to become primarily dependent on the government for subsistence. This is a really old concept in immigration law. I mean, this was really targeted towards Irish immigrants who were living in almshouses during the potato famine. But it was, really intended to be people who had, really complete dependence, and again, that shouldn't be a bad thing, but that's sort of the idea, which is very different than the way people access public benefits today. We didn't have a welfare state when this concept was created in immigration law. We didn't have ADAP. We didn't have Medicaid or Medicare. And we know that a lot of people who use those benefits use those in order to be able to participate in the workforce or to be healthier, and they're cobbling together a lot of different supports. So I think that that's just an important thing to note, that the idea of public charge still remains someone who is primarily dependent. And as a consequence, there's been only two types of benefits that have been considered, and this is currently still the guidance. If you receive cash, or if you receive institutionalization for long-term care at the government's expense. That's it, cash and care. So if you're going to ask today, what on February 25th, 2019, what's the definition of public charge? This is still the definition of public charge: primarily dependent and cash and long-term care. Enter the Trump administration. So the idea of public charge, again, that I think is really important to, as I mentioned, is that it's a forward-looking test. They're not looking to find out whether or not you in the past were primarily dependent. It is whether you are likely to become primarily dependent in the future. So somehow DHS is supposed to have a crystal ball to be able to just look at someone and guess whether or not they're going to be using benefits in the future. So it's really, a totality of circumstances test. It's not just one thing. Oh, you use Medicaid, so you're a public charge. They have to look at your age, your health, your family status, financial status, education and skills, and an affidavit of support, which is it's a promise that's signed by someone who sponsors you. It's usually a family member, that they will be financially responsible for you if you become, if you fall on hard times while you're, in your first years here in the U.S. So next slide, please. Oh, sorry, I forgot I was the one in charge of this. I got it, sorry. Where does this come up? So a public charge test only applies really to people. There's two different tracks, one for people who are in the United States and another one for people who are applying to enter the United States. So they make a public charge assessment when you're applying to enter the United States. If you're applying for a visa, if you're being sponsored for a green card, whatever it is, you're going to have to pass a public charge test. If you are in the United States and you're applying to adjust your status to become a lawful permanent resident or a green card holder, you also have to pass that test. If you are changing your status, you were here on a tourist visa and you change to a student visa and so forth, and if a green card holder leaves the U.S. for more than 180 consecutive days and re-enters, they may have to pass a public charge test in order to come back into the country, even if you've been here for 20 years with a green card. So but it's really just primarily when you're applying to enter and when you're applying for a different visa status. So it's important to know that this does not apply to everyone. It's important to know that green card holders, when they're applying for their citizenship, do not have to pass a public charge test. So if you're a green card holder and you've been here and you're applying for your citizenship, no public charge test. Refugees and asylees, VAWA self-petitioners, survivors of domestic violence, trafficking, or other serious crimes, Afghan and Iraqi interpreters. There's a number of categories that are actually excluded. So I think it's really important that folks make sure that they're even subject to a public charge test before they, grow concerned. Okay, so the first change that happened back in January of 2018. And it was an edit that was made rather quietly to the Foreign Affairs Manual, or the FAM. The FAM is basically the Bible that consulates abroad use to make decisions about whether or not to grant people permission to enter the United States. It is a Bible that has many interpretations, and there are very varying levels of how it's read and how decisions are made from consulate to consulate. So, you might be, processed in one consulate and get one decision, and someone else could have had the same fact pattern, have the same life circumstances, and one person could get denied a visa, another one could get, could have their visa approved. So I think it's important to note that there's great disparities in terms of application. So the big thing that happened back in January 2018 is important to note that they did not change the public charge definition, but in the past, if you had an affidavit of support, if you had someone sponsoring you who signed to promise to be financially responsible for you, that was enough. So if you were marrying someone that was very rich, if Mark Zuckerberg was your husband and he's a billionaire, you didn't have to worry about the applicant, him or herself's financial circumstances. The affidavit of support was enough. And that's changed as of January 2018. They will look at the affidavit of support of your family member, usually, who's the one sponsoring you, but that's not going to be sufficient to overcome public charge. They're now going to look at the applicant, him or herself. Now, what are they going to look at? They're going to look at the applicant's age, their health, family status, financial resources, and skills. So the problem here is that the totality of circumstances test now considers use of non-cash benefits and benefits used by sponsors or family members. So if the person is applying, I'm from Argentina, to come in from Argentina and they have family already in the United States, I could potentially be denied the ability to come in if, for example, they saw that everyone in my family was using benefits. That has not happened yet, but the idea is that they're not just looking at the sponsor's affidavit of support anymore. And that's a big change. I will say that in terms of what that has looked like on the ground, I get a false alarm about once a week from someone telling me that someone living with HIV was denied entry to the U.S. because of their use of programs or this and that. That has not happened as far as we're aware, despite the ongoing rumors. We have not heard of any FAM denials specifically because of HIV status or use of any particular benefits related to, the care and treatment of a person living with HIV. So what we have heard is that if the person doesn't have a job already in the United States before they come over, if they haven't provided enough documentation, a lot of people are getting requests for additional evidence. That is happening. But I just want to be very clear and, keep on sending the reports, our way if you are hearing stuff like this. But, I'm no longer pulling every emergency alarm every time I hear this, because make sure you have all the facts before you, are absolutely sure that sort of the person was denied for HIV status reasons. Again, we have no evidence of this. There is litigation that's been filed by the city of Baltimore that is trying to block the Foreign Affairs Manual changes. That's in court right now. We'll let you know how that goes. Okay, so that's the FAM. Again, the big change being someone being out of the country applying to come into the United States. But the bigger change would be this proposal from the Department of Homeland Security to redefine public charge more broadly. So as I mentioned before it was just whether or not you were likely to become primarily dependent on public benefits. That was sort of that is the definition as of today. But they want to change the definition to be an immigrant who receives one or more public benefits. Again, that is a very different concept than someone being primarily dependent on the government for subsistence. We know many people use SNAP benefits while working one or sometimes two jobs because they're not making enough, at minimum wage to make a living, right? We know lots of cases of people that use one benefit, but that, certainly doesn't imply that they're primarily dependent, and certainly they might need, they get laid off or they have some tough times and they use a benefit for a short amount of time, and then they're back in the workforce. So I think that I want to mention just how radical of a change this is. So this totality of circumstances, so how they're going to assess whether you're a public charge. So these are statutory, these already exist. Again, they'll look at your age, your income and financial status, health, education and skills, family status, and affidavit of support, meaning that they're going to balance those out. There is no algorithm. I can't plug in your age, details about your family, your health conditions, and put out a positive or negative, a determination about whether or not you're likely to be determined to be a public charge. There's a lot of discretion here. But again, it's important to note that no one factor is going to be determinative. So the positive factor for age is you have to be between 18 and 60. That's going to be a positive factor. If you're too old, if you happen to have committed the crime of being over 60, or you're too young through no fault of your own, that is going to be considered a negative factor. Health, so again, no health concerns, that's going to be considered a positive factor. If you're diagnosed with a medical condition, i.e., if you're a person living with HIV, or if your condition will interfere with your ability to attend school or work, that is going to be considered a negative factor. Again, lots of questions about whether or not how that would apply to maybe it wouldn't be considered. Again, there'd need to even be more explanations about what those factors are, sort of, but certainly we see this with cases with people with cancer and so forth. So family, again, it's important to note that they are not going to, so if you're here in the United States and you have U.S. citizen kids, you have dependents that are using benefits, they are not going to look at the use of benefits by the children or the family members of the applicant. So that's really important, and I think a lot of folks we've been hearing have been, taking their children off of programs that are really crucial for crucial developmental stages, and it's unnecessary because their use of benefits will not count. Again, so this is what it really is a poor test. It's a not wealthy test. It's your only heavily weighted positive factor is if you earn over 250% of the federal poverty line or higher. That's a really high standard. I mean, we're talking about in the 60,000s for a family of three. This is not a very low-income family. The negative factor if you're 125% of the federal poverty line or lower. Again, that's going to be weighed against you. But, when you look at 250% of FPL, like anyone who's not earning over 250% of the federal poverty line is potentially at risk to be considered a public charge, which really turns our immigration system into a pay-to-play system where green cards go to the highest bidder, where really it's, enter only the rich. This is a very radically different, and it doesn't even matter if you have someone who's willing to sign an affidavit of support for you, right? When we talk about public charge from people entering from abroad. Education and skills, English fluency, again, is going to be considered a positive factor. So not speaking English, not good, is not good. Your degree, your skills, and your licenses, not being proficient in English, which if you think about that many people are applying to come in to the United States from another country, is weighed as a negative factor, which we know is going to particularly impact countries that are not Anglophone, where people are speaking different languages. So there's a natural advantage to immigrants who are going to be coming from countries where they already speak English. And I don't think it'll surprise anyone on this to know that that primarily is going to be immigrants of color, or would be immigrants of color. Okay, so again, the current policy is that the government just looks at the affidavit of support. and if there's a joint sponsor, and if the individual's income is not 125% of federal poverty low. The new policy would look at the sponsor's financial status. They're also interested in whether or not that sponsor and the applicant live together, and the likelihood that that sponsor would actually provide financial support. Again, a big shift. Important to note that that has not changed. Right now, it is still the way it has been for people who are changing their immigration status, adjusting their immigration status here in the United States. Okay, so what does this, so again, I think that the important piece to note, again, is the most heavily weighted positive factors. There's only one, really, and that is, so there's weighted factors and then there's heavily weighted factors, right? Again, but there is no, I can't multiply a heavily weighted factor by a factor of 4 and say that's how much it weighs, right? It's completely discretionary. So again, the only positive you can have is having more than 250% of the federal poverty line. There's lots of negatives that you can have that are heavily weighted. Health conditions, no unsubsidized health insurance, lack of job, and receipt of public benefits, all heavily weighted. So as you can see, this is stacked heavily in favor of the negative. So again, as I mentioned before, the new definition would be not primary dependence is public charge, but public charge is just being likely to use a benefit, right? That means that they'll still be looking at cash and long-term care. Those are still going to be considered as public charge, but they're expanding it. They want to expand it to include receipt of Medicaid programs, SNAP, food stamps, Medicare Part D low-income subsidy, and housing assistance. So that includes public housing, Section 8 housing vouchers, rental assistance, all that. So the new ones are Medicaid, SNAP, Medicare Part D, and housing assistance. It's important to note that these are not retroactive. So if you are a person or if you're counseling someone who is currently in receipt of those benefits, they are not going to count until after the rule is finalized. And no use of benefits that occurred prior to the finalization of the rule. Again, the rule is still, being back at the Department of Homeland Security. They're reviewing the comments. But still, even after that, there'll be 60 days. So again, it's not retroactive. I think that's one of the most important pieces. Public benefits that are not included, ADAP, so AIDS Drug Assistance Program, disaster relief, emergency medical assistance, CHIP, Women, Infants, and Children, WIC, school breakfast and lunch, transportation vouchers or non-cash transportation services, student loans, and the EITC, the Earned Income Tax Credit, and Child Tax Credit. Those are not included. So I think it's only the new ones that I mentioned. Okay, so again, as I mentioned, this is a really radical change. We're going to sort of keep on going. And I wanted to just say that this really has direct impact not just on individuals who are going to be applying for green cards or to change their immigration status, but the reality is 1 in 4 kids in this country lives with an immigrant parent. And that means a quarter of all kids are potentially in a situation of having their parent have to make decisions about whether if one of them is applying for a green card, they might be worried and they might misunderstand this and take the kid off of CHIP or Medicaid or another benefit because they're worried that it could impact the the immigration status of one of the parents. So I think that that's really huge. So I'm going to give you just a quick example. This is a theoretical person, Clara. She's from Nicaragua, because one of the other big issues I think also to mention is most people who are applying to get their green cards aren't eligible for a lot of public benefits. So I think that that's a really important piece. There's a 5-year waiting period for almost every public benefit. So if you don't have a green card already, you're not going to be eligible for Medicaid, right? So many people will ask, well, who does this affect? Well, this is where programs like the temporary protected status come in. So I know that folks have been very active on trying to fight this. This is also stuck in court. But temporary protected status is a program that benefited a lot of people who were fleeing situations of crisis and have been living here with Social Security numbers, with work authorization for many years. The White House wants to end TPS, and we're in the process right now of seeing when exactly that's going to happen. But what that means is, in this example, Clara being from Nicaragua, who had TPS since 2001, and the White House has ordered an end to TPS, but she's living with HIV, and because in New York State, if you have TPS, you're eligible for state-funded Medicaid, she has Medicaid, right? And her husband wants to sponsor her for a green card. So the question is, will Clara be determined to be a public charge? Well, here are the factors. So one is positive factors. Age. She is in the age bracket where that's positive. Negative factors. Income. Potentially negative factors. Health status, right? And, income we know because if she's eligible for Medicaid, she's below a certain threshold. But I think the important thing to look is when we look at this is that she's afraid that the use of Medicaid will cause a problem for her green card application, but it only will count if she uses Medicaid after the rule is finalized. So, this is going to be the situation that a lot of folks are going to be in, which is in that 60-day waiting period. Let's say they finalize the rule and they say, okay, the rule is finalized, it's going into effect. Again, there'll be litigation and it'll probably be held up in court for a while. She will have 60 days to make a decision, right, about whether or not to disenroll from programs so that when she applies, she can say, no, I didn't use the program until, I didn't use the program. It didn't count for public charge because the rule wasn't finalized yet. And that is not a situation anyone wants to be in, right, which is why we need to continue fighting this rule. But I just want to emphasize it for someone like Clara. She has TPS. So that explains why she was eligible for Medicaid without having a green card. But she's using that benefit prior to the finalization of the rule. So I think that's the sort of important piece that I want to mention. Okay, so again, I think the biggest concern that we have is about the chilling effect, and I'm going on too long. Lots of people are very confused about this. You have to be an immigration lawyer basically to be able to figure out who is going to be impacted and how, and honestly, most immigration lawyers are as confused about this as everyone else. And so we already know there was a survey in California recently. 2/3 of health providers reported an increase in parents being afraid of enrolling their kids in Medicaid and WIC. We've had parents returning breast pumps to WIC agencies around the country, worried that that's going to impact their immigration application. It doesn't. But again, confusion about this very confusing totality of circumstances situation is leading people to make decisions, but that also in some cases are life and death decisions, right? I mean, I've met a person who was receiving cancer treatment funded by Medicaid, and she decided to get off of cancer treatments because for her, staying with her husband was more important for her than maybe dying because she didn't have access to the treatments that she needed. And that's really where people are making decisions. I mean, what was crazy about that situation is neither of them would have been impacted by this, but she was just so scared from what she'd read in the paper that she made that decision. Okay, so again, again, as I mentioned, 1 in 4 kids have an immigrant parent. We imagine that as many as 26 million people nationwide could potentially be impacted by this rule if it were to be implemented. And again, probably no one will be surprised that the majority of them are Latinos, Asian Pacific Islanders, Black and African immigrants, and the smallest percentage impacted would be less than 1% of the white population identified by the census. But a third, 33.4% of all Latinos could potentially be impacted by this, right? So this is very targeted at a very particular community. Again, the final thing just to note, and we, I think we can shift to the next piece, and is just that I want to just talk about how to talk about this to immigrant families. Is number one, the public charge rules in the U.S. have not changed. Public charge still only looks at cash and long-term care. The proposed regulation does not consider benefits that were used before it's final. Like I said, Clara was using Medicaid before, but it's not going to count against her unless she's a recipient of Medicaid benefits after the rule is finalized. There'll be a 60-day cushion period. The regulation doesn't apply to all immigrants. Privacy of personal protection is protected by law on all these programs, and we can fight back. So I think that the number one thing right now is that we're still just trying to let people know nothing has changed and that we don't see any benefit whatsoever to disenrolling from programs right now. And I think Nana's going to talk to you a little bit more about how to get involved, but we are going to continue to try and block the chilling effect. The Protecting Immigrant Families campaign, which is co-led by us, National Immigration Law Center, and the Center for Law and Social Policy, are continuing to after the comment period, fight this campaign. And we're also particularly looking to document the chilling effect. So I don't know if Nana will talk about this a little bit, but just if you're hearing stories about people that are not accessing benefits that they're legally entitled to because they're scared about immigration issues, let us know, right? Because we can't demonstrate this harm, and because so many people are so scared, if we don't have it documented. So I think that's the idea, and we really want to try and block this from ever happening, and we're still working on that. So the 3 ways to stay engaged, I will say, is people can join the protectingimmigrantfamilies.org website, which has a lot of resources on it, and bit.ly PIF campaign. You can join the email list. So with that, I will turn it over to Positive Women's Network.
And Nana, this is Sarah from AIDS United. Thank you so much, Jackie. We can pause. We actually have one question in the queue that so folks can put questions in the chat box. You'll see a little icon on the bottom left of your screen. We'll either answer it now or at the end. But we did get one question specific to Dreamers. Someone wondered how the change in definition might affect a dreamer who's in college, who happens to be living with HIV and needs assistance for both cost of school and costs associated with their medical care, or how it might affect an immigrant who isn't a dreamer but is interested in pursuing higher education.
Right. So DACA, people with DACA, currently the DACA program is still in effect. NILC, National Immigration Law Center, is still litigating along with a lot of other people stuck in court. SCOTUS is going to be hearing this case. And what that just means is that right now there's really no path for people with DACA to actually adjust their status, right? If there was an opportunity, if that person was married to a U.S. citizen, and so forth, they'd have to pass the public charge test. But right now, one is, that there are no ways for most people with DACA to adjust their status. But 2, the rule hasn't gone into effect. So I think that the issue is really going to be for that young person, if this rule does go into effect and that person is living with HIV, is going to have, and they think that they might have an opportunity to adjust their status in the future, which we hope all of us will one day pass comprehensive immigration reform, or at least a pathway for people who are undocumented and under the current DACA program. But it's going to be tough, right? Because they're going to have to, I think that, they're going to have to make decisions about whether or not, if this rule is finalized, they use benefits after that rule that fall within those categories. And I do want to mention that the student loans don't count, right? So as you remember, there was cash and care as our current policy, and they want to expand it to Medicaid, Medicare, housing, and SNAP and Medicare Part D, not all Medicare. So that's not if it's not on that list, it's not counted. So that individual that you mentioned would have to be maybe thinking about Medicaid, but wouldn't have to worry about student loans.
Great. And I have one more question, and then Nana, we'll turn it over to you. Does the public charge rule change only affect folks who access federal programs? What about local, county, or state benefits?
Yes. So that was sort of one of the big questions that we had, when the rule came out. Initially, earlier draft said state and local benefits would be counted. Right now, it's not written so that state and local benefits are counted, so that states could come in and fill in that gap. But yeah, so for right now, we do think that states and localities will have a really important role to play in sort of filling in those program gaps. But the issue there is sort of the eligibility. Any person who's likely to be eligible for those programs is likely to not hit the income thresholds. So a lot of this kind of totality of circumstances are, if you're eligible for Medicaid, even if you don't use it, you're probably also going to be dinged because of your financial status, right? So that's the sort of tough thing with all this.
Great. Thank you so much, Jackie. Nana, we're going to turn it over to you.
Okay, great. Thank you so much. Does my sound okay?
Yes, you sound great.
Great. Well, thank you so much, Jackie, for that really excellent overview, and thank you to AIDS United for organizing this webinar. I think, from the number of folks we see participating on here today, it's clear that this is an issue that's really important for the HIV community, and we really appreciate all of you being here. So I'm Nana Khanna with Positive Women's Network. We are a national membership body of women and folks of trans experience living with HIV. We're all over the U.S., and we primarily work on federal policy that's grounded in human rights and gender justice, and we also advocate at the local and state level. And so I want to talk a little bit about, kind of exactly what this public charge proposal means for communities impacted by HIV, and specifically, sort of where we're able to triangulate and figure out what the actual impact might be. That said, there's a lot of data that is not really available yet, and a lot of this is sort of based on what we've seen. So I think, as Jackie sort of articulated well, the public charge changes are currently a proposal. They haven't yet gone into effect. However, there are lots of other changes that have come from this administration, and this is part of a much bigger conservative agenda to sort of fundamentally reshape our immigration system and to think about who deserves access to benefits, who deserves to be here in the U.S., and who deserves really dignity and quality of life once they're here. And so I think it's important to think about the public charge changes in the context of all of these other things that we know have happened and are coming, from travel bans to rhetoric that's been really violent to policies that are playing out at the local, state, and federal level. And so in terms of people living with HIV, it's clear that there is a lot of overlap. I'm sure when we saw those slides about the programs that were being targeted earlier, they're very familiar programs. Here in the U.S., we know that people living with HIV are living at the intersections of multiple different oppressions, and some of that is certainly related to immigration status. And we know that people living with HIV in the U.S. are mostly low income and have actually been forced to be low income for a long time because of the way that qualifying for health care and medications that are really expensive basically forces people, in most states in the U.S. to live at a very extreme poverty level. So we also know that there are gender disparities in poverty for people living with HIV. So, for example, the most recent Ryan White client-level data report showed us that higher percentages of women and folks with trans experience in the Ryan White program are living below the poverty level than men in the program. So 72.1% of cisgender women and between 65 and 77% of folks of trans experience were living at or below the federal poverty level, whereas that number was still disheartening but not quite as extreme for cisgender males. 58.9% were living at or below 100% of the federal poverty level. There's very little data actually on kind of trying to assess how low-income folks living with HIV really are and how many people they're really taking care of. But what we have been able to find from some research that PWN did is this second graph you're seeing on the right-hand side here, where you can see that about, almost 90% of 180 women living with HIV we surveyed around the country were living at or below 138% of the federal poverty level, and a significant percentage, 42.4%, were taking care of dependents in their household on these incomes. So this is just to give you a sense of, how much folks living with HIV are really likely to be relying on these types of services, and also taking care of other people on the benefits that they're receiving, whether that is SNAP or Medicaid or other forms of benefits. So specifically, we saw that there are a number of these programs that are targeted under the public charge program. And by the way, if you don't know the UndocuBlack network, I recommend checking them out. This is an organization that is advocating for Black immigrants in the U.S., which is often a community that is sort of underrepresented and invisibilized in the immigration discourse, although we know within the context of the HIV epidemic that it's a really important community that is facing both a lot of stigma and isolation and living at the intersections often of HIV and vulnerable immigration status. So in terms of looking at people living with HIV and the programs being targeted under the public charge rule, I haven't been able to find any actual nationally representative data on the SNAP program and how many people living with HIV are on that. However, from our own research as PWN, we do know that about over 40% of our members are utilizing SNAP. We also know that Medicaid is the single largest payer of healthcare coverage for people living with HIV. It's covering more than 40% of people living with HIV in care nationally. And a PWN survey found that 44% of our members are relying on Medicaid. And of course, there's been a lot of concern about the Medicare Part B program right now. We know that Section 8 is really important to our communities. So I think it's obvious that there's a lot of overlap between these programs and the community of people living with HIV, the programs that are being targeted under the public charge proposed changes. Part of why this is important is not just because of the actual situations where folks would be required to disenroll, but as Jackie was saying, the way that a climate of fear and a culture of fear is being created so that people may disenroll from programs even if they don't actually have to, and that this can actually have an impact not just on their own health but on their whole families and their communities as well. So we know that this rule is really targeted. It's really targeting immigrants with pre-existing conditions. So having a medical condition that is likely to require extensive treatment or institutionalization is a heavily weighted negative factor, as is being uninsured or having the financial resources to pay for medical costs associated with that condition. Well, that sounds like most people living with HIV I know. And this is no accident. If you look at the way the Department of Homeland Security actually wrote the preamble to their proposed rule changes, they are directly recognizing that disenrolling or deciding not to enroll in these programs could lead to worse health outcomes. So they're completely acknowledging that, especially for pregnant or breastfeeding women, infants, or children. They talk about how this could lead to reduced adherence to prescriptions, increased use of the emergency room, instead of relying on preventative care and regular screening, folks maybe just showing up at the ER. Homeland Security also acknowledges that this could lead to increased prevalence of diseases. So it's really pretty hard to think about how we might get to the goals that the administration has laid out in terms of ending the epidemic in this context. Also, we know that these changes could impact access to private coverage. So the Department of Homeland Security is proposing to consider whether someone has applied for a public benefit, even if they never actually enroll. And many immigrants, including those who are lawfully present, this doesn't apply, just to folks who are undocumented. Many immigrants are working in industries that don't offer health benefits to their employees, like retail, like hospitality, like agriculture. And so in many state-based marketplaces, in order to streamline enrollment, when somebody is applying for marketplace coverage, a Medicaid application is automatically generated. And once the person is deemed ineligible, the marketplace can determine their eligibility for premium tax credits. And so if the marketplace submits a Medicaid application, even if the applicant doesn't enroll, there's a question about whether the green card application could actually be put at risk in the future. So, so this could create fear of potential consequences for immigrants that are enrolling in marketplace coverage. And this is Amanda Lugg from African Services Committee, which has done some incredible work and is providing services directly to immigrants in New York City living with HIV, really thinking about the intersections of the public charge rule and HIV positive status. So we can see that there are a lot of ways in which this new proposed rule changes could really devastate people living with HIV who are immigrants. These changes are bad for individual health and they're bad for public health. So this emphasis on medical conditions basically creates almost a pre-existing condition exclusion for non-citizens who might later seek to adjust their status. So this is not just a poor tax, although that is a terrible thing, a pay-to-play model. And by the way, this wouldn't be the first time in U.S. history that we've had a pay-to-play model for immigrants entering the country. But this is actually reshaping an immigration system also around those who are considered sick or well. And so any immigrant with a serious medical condition under these changes would basically have to overcome extreme hurdles in order to not be deemed a potential public charge, especially if they can't show they have private insurance. And the public charge changes are a piece of that. The FAM changes are potentially a piece of that too. I think that there may still be, some open questions and certainly data to be collected on what sorts of denials are happening and what is being sort of given as the reason for those, as opposed to what some of the other reasons might be. So this basically creates for immigrants living with HIV or who think they might be at risk for HIV a direct incentive to avoid medical examinations like HIV screening. Because if you're discovered to have a health problem, especially an expensive health problem, that could really compromise ability to adjust status in the future. So what do we know about what's already happening? Well, there is quite a bit of data and research being generated by the Protecting Immigrant Families Coalition and many of their partners looking at what's actually happening. So we're already seeing that immigrants are foregoing medical care, and this is not just related to public charge, but this is related to, like, as I was saying, a broader conversation that's happening around immigration, around access to benefits, and around, fear from the administration. So according to the Association of Community Affiliated Plans, they are projecting, based on data they've collected, that nearly 150,000 fewer individuals may be accessing Medicaid in Texas because of when the rule was leaked, even before the official proposed rule came out for comment. Also in California, there's data that there have been a number of calls from enrollees, Medicaid enrollees, expressing their fear around being considered a public charge and asking about how to disenroll from the program. There's also some early data that has come out from California's open enrollment 2019 process. So this data just came out, I think, in the last couple of weeks, showing that consumers of Covered California, which is basically our state program, who preferred to speak a language other than English, had a larger drop during open enrollment for 2019 than other groups did. So it does look like there are some chilling effects actually happening. For the SNAP programs, we also see data showing that folks although there was a huge increase actually in immigrants participating in SNAP over about a 10-year period from 2007 to 2017, preliminary data from 2018 showed a 10% drop in enrollment among immigrant families eligible for SNAP who have been in the country for less than 5 years. And so this study was looking at over 35,000 mothers of young children in 5 U.S. cities, and basically found that while SNAP participation had been increasing among immigrant mothers whose families qualified for nutrition assistance from 2007 to 2017, that SNAP participation rate rose to 43% by 2017 and to 44.7% among families whose mothers had been in the U.S. for 5 years or more. But in the first half of 2018, the data showed a distinct drop in SNAP participation of about 10%. So this is showing that, kind of fear of a crackdown through public charge, through other types of attacks on immigrants utilizing benefits may be leading to disenrollment from programs and lack of participation in programs. Also, we know that this is having the immigration climate and concerns about things like public charge are having severe mental health impacts on immigrant families and communities. And so, although these proposed changes to public charge haven't actually gone into effect yet, we're already seeing an impact. And I think it's important to sort of recognize that, and that fear, uncertainty, and confusion are a deterrent to enrolling in programs, to newly enrolling, and to staying enrolled, and that this is placing entire families at risk. From an HIV perspective, it places both individuals at risk for poor health outcomes, but it also creates It also can create severe stress for the family in terms of benefits that they may have been relying on, and it makes it basically impossible for us to achieve HIV-related public health goals that really require everybody who's living with HIV knowing their HIV status, accessing care, accessing treatment, having a suppressed viral load in order to minimize onward transmission as well. So in terms of thinking a little bit about what can we do, accurate messaging and information matters. And so it matters, that we're communicating to clients that the rules have not actually changed yet, that, as Jackie emphasized, the rule would not be retroactive, and that receipt of benefits by the individual are the only factor, not by family members are the factor. But it's also important to keep countering anti-immigrant rhetoric and to acknowledge that immigrants are not the only ones relying on these programs. About a fifth, in fact, of U.S. citizens are also relying on these programs, and that this is part of a much larger political and rhetorical effort to really vilify immigrants and paint them as a burden or problem to our society, when you really have to wonder where this country would be without immigrants. At a state and local level, I know there was a question about that earlier. There are actions we can take. So partly because of this, lack of clarity around sort of what participating in state and local programs would mean, it is important to support sanctuary policies at the local and state level. And so as one example, we had SB 54, the California Values Act, which passed last year. It limits collaboration between local law enforcement and the Department of Homeland Security. It also protects against immigration enforcement in sensitive locations, including healthcare facilities and schools. And so right now there is a bill called the Protecting Sensitive Locations Act, HR 1011, which would prohibit immigration enforcement in a set of sensitive locations, including courthouses, schools, community centers, houses of worship. This is something that, you can look it up, HR 1011, see if your representative has signed on to it. If not, contact their office and see if they will support this and inform them about why it's so important. But also laws protecting health information privacy, looking at options for presumptive eligibility programs like Medicaid eligibility programs that don't verify information against federal databases, but that just sort of like presume that folks are eligible. And also looking at policies that would prohibit Medicaid programs from retaining citizenship or immigration information are things that can be explored. For healthcare facilities, there are multiple sort of best practices, including having written policies and procedures for gathering and handling information, especially information about immigration status, citizenship status, national origin, thinking about how, policies that providers can use to avoid including that information in any medical and billing records, having healthcare facilities restricted to collect this information only for the person seeking care, not for family members, responding to requests by patients, including their parents or guardians or caretakers, to remove immigration status information from their medical records as permitted by law, educating patients about their privacy rights, letting them know which healthcare information is protected by federal and state laws, and this varies from state to state. And then, kind of making sure that information about immigration status is accurately reflected in notices of privacy practices, what is protected by privacy laws, and making sure that this information is available, of course, to clients and patients with limited English proficiency in the languages that are most commonly spoken. Also, there are other related attacks on immigrant access to the safety net. So, for example, right now, there is a notice of proposed rulemaking from the Social Security Administration, which just came out a few weeks ago, that would eliminate the inability to communicate in English as an education category that's evaluated under disability claims. And so basically, in a nutshell, what this means is that the Social Security Administration is trying to make it easier to deny assistance to non-English speakers. It's estimated that about 10,000 would have applications rejected. And this proposal is specifically targeting folks who are documented and U.S. born, because that's who qualifies for Social Security. So comments are due in a little over a month, and this is the link here to the Federal Register notice. So I encourage you to check out Protecting Immigrant Families for a lot of other useful information, as well as the National Immigration Law Center, the Urban Institute, which is collecting a lot of research on kind of like how these policies are impacting the community, and these proposed changes are impacting communities. And I think with that, I'll wrap up and leave a little time for any questions.
Thank you so much, Nana. That was really informational. So I am going to just move along to our AIDS Watch slide. Just as a final plug, the AIDS Watch is another opportunity for you to raise your voice on immigration matters, as well as HIV health policy. It's all related. So at this point, we don't have any questions in queue. You'll see a little blue icon on the bottom left of your screen if you want to chat us a question. We still have some time for Nana and Jackie. So I'll pause for a moment if you want to add anything.
I just wanted to add one thing, sort of just to point out that, and thank you, Nana, for bringing out the issue of the Social Security Administration other proposal. We're getting hit from all sides. On one hand, in the public charge proposal, they said that they were going to count English as a negative fact, not the inability to speak English or limited English proficiency as a negative factor, because they said it would be hard for the person to get a job. Meanwhile, in the Social Security proposal, they're saying that they're trying to eliminate English proficiency as one of the education vocational factors for eligibility for Social Security benefits for people with disabilities, because they're saying that they think those people can probably get jobs. So in the same, I mean, just watching, it's like they'll use, it's just an attack on people with limited English proficiency, right? It's not even, and we don't really think it's helpful to mention both of them, to cross-reference them, because ultimately they're both trying to say horrible things about people with limited English proficiency. But I just want to just mention the ways in which these proposals are even internally inconsistent, and that the White House is putting out stuff, that doesn't make sense even within their own logic, right?
Mm-hmm. We did have a question about if these slides are going to be available. Yes, the slides and the recording will be available. You'll get an email through the ReadyTalk system once they're up. But you can always just check them out at aidsunited.org/webinars is where you can find all of our recordings and all the slides from all the webinars we've hosted. But you'll get an email when that is up, which should be later today. We don't have any more questions in queue, but we still have a few more minutes. So I'll put your questions in if you have any. While we're waiting, Jackie or Nana, do you have any closing thoughts that you'd like to share?
I mean, I just would like to say that I'm really impressed by how, people have really mobilized around this. If you had told me 2 years ago that we were going to get over 250,000 people to submit comments about a obscure change in a really old immigration law that is really hard to understand, I would have not believed it to be possible. And I think that just it actually shows that maybe we have to keep fighting, and that it's not over yet. And if we can get 250,000 people to come out on this, then just imagine what we can do. So I think please do join the protectingimmigantfamilies.org list. This is just the beginning, because in addition to, this won't be the presidency and the administration forever. And, I think we are really thinking about, for so many years, talking about immigration and access to public benefits at the same time has been a taboo. Now I think that actually this is an opportunity to actually seize on this attack, to actually say, not only are we going to try and stop the administration from attacking immigrants' access to benefits, we're going to actually ask for there to be an expansion, and if there's a Medicare for all bill, it should cover immigrants too. And so I think that there's a way in which we can turn this into some victories, I think, actually, in the long term.
Great. And we actually have one more question in queue, and then, Nana, I'll ask you if you have any closing thoughts. Will clients receiving Ryan White and ADAP be affected if they want to apply for a green card?
Nana, do you want to answer?
I'm not, those programs are not specifically mentioned in the proposed changes to the public charge rule.
Yep. So if they're not specifically mentioned, then they're specifically excluded. So it's only Medicaid, Medicare Part D, housing, SNAP, and cash and long-term care. That's it. If we didn't mention them in that list, they don't count.
And I will say that said, you know, we don't really want the administration to start looking at any new programs to target. So if they're not mentioned, if they didn't specifically come up on today's webinar and are not specifically mentioned, they're not included, and we don't really want to give them ideas about new places to look at targeting immigrants.
Great.
Thanks, Nana. Just one more plug. If you want to stay up to date on all the latest information around public charge and people living with HIV, I encourage you to sign up for AIDS United's policy update and all of our other news and updates and funding opportunities and announcements. It's at the bottom of the AIDS United's main webpage. Just enter your email address and click on the interest that you want to get emails about, and they'll come in your inbox when they happen.
I do want to say one more small thing, which is I think we absolutely have to keep fighting back at these attacks at the federal level, and please don't take your eyes off local and state level opportunities to both, kind of increase sanctuary and also move some real progressive policies on immigrants. So if you're part of an organization that's providing services, really think about and look for where you could be in coalition with immigrant organizations at your local and state level. They need all the support they can get. And also, the 2020 election cycle is already here. These are questions that we can be asking of any candidate running for office that is completely nonpartisan, to raise questions and put them on record about their commitments to ensuring access to health care and the safety net for immigrants living with HIV.
Thank you so much, Nana. Thank you, Nana and Jackie, for taking the time, and thank you for all of you who joined the webinar. And you'll get a note when this recording is available, and if you have any other questions, send us a note. Our contact information is at aidsunited.org, and we can also put you in touch with the presenters. Thanks, everybody.
Thanks so much.
Thanks for having us.